Sir, please start.
Please start. Joshi sir, please start.
Sir, kindly unmute yourself and please start.
Yes.
Okay.
Yes, sir, please start.
So good evening, everybody. Good evening, my friends. Good evening, my dear IPNs. Today we are going to conduct another session of our very interesting, unique program that be the Sherlock Holmes and crack the case. Since last 4-5 times we have been very nice discussion and very beautiful outcome, and it was a very nice gift of gift of very thoughts to the people. So dear friends, I welcome all to you to this all of you to this program. I welcome our dear President, Dr. Sanjay Pakmode sir. Sir, please welcome here. I welcome Dr. our dynamic and dashing Secretary, Dr. Amol Pawar sir. Then I welcome our scientific committee person, Dr. Minas Sheikh sir. The today's experts are Dr. Lalit Une sir, who is a professor and HOD in the Indian Institute of Medical Sciences and Research at Jalna. Very my close friend. We had been together at many places as an examiner also. I welcome Dr. the second expert, Dr. Kishore Rathod sir. He is also professor and HOD at Shankarrao Chavan Medical College, Government Medical College at Nanded. Welcome, sir. Then I welcome moderator Dr. Dimples Jain madam. She's a consultant pediatric endocrinologist and hepatologist. She's working in the Jupiter Hospital Thane. She is expert in liver transplant and gastroenterologist of the children. I welcome our presenter Dr. Jatin Hanavarkar, who is a second year resident from Jupiter Hospital. So now I request Dr. Sanjay Pakmode sir to give the address.
Thank you, Sanjay Joshi sir. Namaskar. Welcome to the MahaIP platform. As the sir has rightly said, this is a wonderful journey of cracking the case like Sherlock Holmes. Now, it has been named as a Sherlock Holmes because in all these cases which we have discussed in the past, were discussed on that particular line. As the Sherlock Holmes, the character, which is which means in the history has made a records by his means extensive knowledge, logical thinking, logical reasoning, analytical thinking, and keen observations. And these are the qualities which we also require in solving a particular case. No doubt the cases may be very simple at the end, but really it requires a lot of efforts, and our experts are also putting a lot of efforts. It is very well said, the destination is not important. It's a journey which is important. And in these cases, we found it that journey which begins with the case and it ends in the diagnosis, whether we diagnose the case or whether we don't diagnose the case. At least we try to reach to the case as near as possible. But whatever the symptoms, whatever the presentations, symptoms, signs, then the clinical examinations as told by the presenter, and then it is analyzed by our experts, and which leads finally to a concrete thing. Something means sometimes it is diagnosed and sometimes we reach to the near diagnosis. So it's a good means wonderful means activity in the month of this part of MahaIP, and all the viewers, MahaIPians definitely enjoy this particular program. So let me welcome all the today's experts, Dr. Lalit Une sir, with whom I met at Pune in the Pulse program, and Dr. Kishore sir, and moderator Dimple Jain madam from Jupiter College Thane, and our presenter, wishing you the very good luck, Dr. Jatin, and also my MahaIP office bearers, our dynamic secretary, Dr. Amol Pawar, then Dr. Minhaj Sheikh sir, who is doing extensive, means very wonderful job up as a chairperson for this scientific program, and today's MOC Dr. Sanjeev Joshi sir, and all the other office bearers of the MahaIP and CIP, and all the attendees who have joined today's program. So let us enjoy and go ahead with the program. Over to you, Sanjeev Joshi sir.
Thank you, sir. Thank you very much for your kind words. Now I request our dynamic secretary, Dr. Amol Pawar, sir, to say a few words.
Thank you. Thank you, respected Sanjay Joshi, sir. Friends, welcome from Team Maharashtra IP to each one of you, Dr. Sanjay Pakmode, sir, then all the experts, Lalit Tune, sir, then Kishore Rathod, sir, Dimple Jain, madam, renowned gastroenterologist from Jupiter Hospital, Thane, and also presenter Dr. Jatin, all the CIP EBs, I can see Rajesh Kulkarni, sir, then our treasurer, Dr. Ravindra Sonone, sir, and Jai Sri Deshpande, ma'am, Palghar IP president, and all the attendees, and Dr. Meena Sheikh, sir. Also, this has been a very good journey this year. Already we are continuing this program with different name this year. Mahapi Case Challenge was there for last 2 years, and now is Sherlock Holmes. So as you are seeing, Dr. Dimple Jain ma'am is there. So mostly this is a case related to GI tract, and Jatin will be unholding this case. So this is almost ninth episode of this year, and the very well coordinated program by a team of Maharashtra IIP, scientific team of Maharashtra IIP, headed by Dr. Meena Sheikh sir, and well coordinated by all the other members of committee, and a very well attended program. You can anytime go to Maharashtra IIP YouTube channel, and you can in your free time you can watch these programs. All the PG students, for them it is very useful program. So I will be forwarding the compiled link shortly within next 2 to 3 days to watch your favorite this Sherlock Holmes or other programs also. So good luck to Jatin for today's case presentation. And also, as we know, the central IP elections are around the corner in next month. So I will request on this platform to each one of you to vote for the deserving candidates, and myself and Sanjay Pakmode sir will be communicating with you on WhatsApp, and will be appealing you to vote for the right candidates in the voting period. So thank you one and all, and over to you, Sanjay Joshi sir.
Thank you, Amol. Thank you. The basic concept of this program was the same, that not the diagnosis, but the various messages during the journey, during the approach are very important. And last so many cases, we have seen that. I now request Dr. Meena Sheikh sir to say a few words.
Uh, Sir, I will not take. I will do one request. Lalit Tune, sir, you just adjust your camera, sir. Lalit Tune, sir. Yeah. And I'm okay, sir. I will request Sanjay Deshmukh sir to have few words, and then we'll proceed.
Okay, sir.
Sanjay
Then,
Deshmukh. Yeah, then we'll or Sanjay,
Yeah.
Amol, Sanjay. Yeah,
Thank
yeah.
you, thank you,
Yeah.
thank you, Dr. Meena, sir. Good evening.
Good evening.
I'm extremely sorry. I'm just traveling on the way to one place. I'm thankful to all the dignitaries today who joined for the interesting session on the Friday by Mahapi platform. And I welcome the Jupiter team. I think it will be interesting to dialogue the case presented by the Jupiter student. And my best wishes to the academic activity of MahaIP. Thanks. Extremely sorry I'm not able to continue because I'm traveling. Dr. Joshi sir, Dr. Amol, Dr. Pakmode, sir, thank you. Thank you very much.
Okay, sir. Then, before wasting much time, I think we'll go to the case. Now I request.
Introduction.
Yeah, and I'll go to the case. The today's experts, Dr. Lalit Une sir is a professor and HOD in Indian Institute of Medical Sciences in Research at Jalna. Dr. Kishore Rathod sir, our second expert, our second expert is a professor and HOD in Shankarao Chavan Medical College at Nanded. Our moderator, Dr. Dimple Jain madam, is a consultant pediatric gastroenterologist and hepatologist, and she's an expert in liver transplant. She's from Jupiter Hospital, Thane. And our presenter, Dr. Jatin, is a second-year resident from Jupiter Hospital. So now I request Dr. Jatin to please start his case.
Thank you very much, sir. I would like to share my screen now. I hope it is visible now to everyone.
Yes, it's visible.
Make it full screen, Jatin.
Yes, sir.
Yes,
So
it's
good
there.
evening, all.
Good evening.
I am Dr. Jatin. I am a DNB pediatric resident at Jupiter Hospital, Thane, along with Dr. Dimple Jain ma'am, who is a consultant at Jupiter Hospital, Thane, who is a pediatric gastroenterologist. We would like to start case number 1. Our topic is approach to recurrent vomiting. So let's dive. We have a 6-year female child who is vomiting since the last 3 years. The vomiting is recurrent in nature, occurring once in a month, which is non-villous and non-projectile. Each episode lasts for 2 to 3 days, 1 to 2 bouts of vomiting associated with abdominal pain. After 2 bouts of vomiting, child becomes excessively drowsy with slurring of speech.
Stop. Yeah. So, how would we like to proceed in this case and request our experts to comment?
So this is a 6-year-old child and the symptoms since last 3 years. In between these two symptoms, how was the child?
So, the child is asymptomatic in between the episodes.
Okay. So can you a little bit elaborate on this episode of drowsiness, whether it was unconsciousness, altered sensorium was there or not?
So, what the parents mentioned is after every episode of vomiting. So, the vomiting used to be only 2 to 3, but after that, the child used to be excessively lethargic. There was no altered sensorium. The child was oriented to time, place, person, but would prefer to sleep after the vomiting episode and used to feel very tired.
And what is the diurnal variation, madam?
No specific diurnal variation.
Okay. No vomiting during sleep or night hours. Is that?
No, no.
Oh.
Most of the vomitings were during the daytime.
Okay.
Any other questions?
Any history of hospitalization in the past?
Yes. So there was Jatin next.
Yes. So there are history of similar episodes in the past, once 4 years back and once 1 month back. But the child was better in between the episodes.
And during that episode 4 years back, the child was hospitalized in view of the slurring of speech and the drowsiness. So that time the child was evaluated. Yeah.
Also, the mother gave the history that child vomits post milk and milk product ingestion. In view of such episodes 4 years back, MRI brain was done in the past, which suggested of the following: giant cisterna magna with retrocerebellar cistern.
Right. So would we give this importance in the child?
So before that, I would like to ask few questions. Are there any associated symptoms other than these two symptoms?
No. Otherwise, the child is well. The only positive history here that we got was the child, whenever the child, so a vegetarian child, but whenever she used to have milk and milk products, she used to have vomiting.
So basically, it's related to food.
Dislike for milk. Yes.
So
she had a dislike for milk. Yes.
So is there any history of rash, itching?
No.
Any skin lesions?
Okay. So for food allergy.
Food
so
allergies.
there was no history of any suggestive of any food protein-induced enterocolitis syndrome, like diarrhea, rash, loss of consciousness. Nothing was there. Any urticaria, nothing was there. And this altered sensorium also, the child used to just sleep after the vomiting for some time, rest, and would get better the next day. So out of the multiple episodes that happened, child did not require hospitalization every time, was hospitalized only once.
How this child is growing over the years?
Yeah. So the child is maintaining within the growth centiles. When the child presented to us at the age of 6 years, her height and weight both were between the 5th to the 10th centile.
Any family history of any disrupted families or any illness in the families?
Yes. So this history, in fact, we got later. We'll come to that. So there is a family history of multiple deaths in the family. So the maternal uncle, and we drew a four generation family chart where there have been multiple male losses in the family. So multiple newborns, multiple males in the newborn period had died on the maternal side. That's a very good question, sir.
Multiple newborns died.
All the male ones. And they all died during the neonatal period.
And general examination, systemic examination, anything positive clue we got?
So, Jatin, next slide, examination.
Yes. So on examination findings, vitals were stable. Anthropometry, weight and height were in between the 5th to 10th centile. No pallor or icterus. On CNS, child was preferring to sleep but easily arousable and responding to verbal commands. No evidence of any neck stiffness. On per abdomen examination, it was soft, non-tender, and there was no organomegaly.
So there was no icterus. There was, I'll request the experts to.
General examination and systemic examinations, they are within normal limit.
Yes. And an important finding when this child presented to the OPD with vomiting, and after that the child was drowsy, there was not much dehydration. So there was no significant tachycardia amounting to the drowsiness that the patient child had, the lethargy and the drowsiness. So we just want to know, basically, of course, it's not like a straightforward case, but we just want to know which system are we looking at in this child?
So basically, first of all, growth is child is growing well. CNS, there is no marker, like there is no focal neurological deficit or no neurological deficit. Hepatobiliary system seems to be normal because the child is suffering from more than 3 years, but there is no jaundice or no other marker present.
Yeah.
And so picture, so any other basic profile you'd like to see the child?
Okay.
CBC, LFT, KFTs.
So I'll just say, because in between there are a few slides which might give the case. So the CBC was normal, within normal limits. The liver enzymes were normal. There was, so LFT was complete bang normal, CBC was normal, electrolytes were normal. What else would we want in a child who is presented like this? So our
blood sugar?
Yes, HGT, yes, sir. So when the child presented to the OPD, and HGT was done at that time itself, which was normal.
Okay. HbA1c and fasting post meal, they were also normal?
We didn't do a fasting post meal, sir. On that, at that time, it was a random blood sugar was normal.
Urea creatinine?
110.
Urea creatinine?
Yes, sir. So renal cause.
Renal, yeah.
Okay. So that was also normal. But I would like to again focus on the family history that you asked, sir. So multiple male losses. So what would that indicate? So there was on the maternal side, so maternal uncle had died and there were multiple male losses. So we are looking at an X-linked disorder, as you rightly said. Yeah. And probably a metabolic cause, as somebody has already mentioned. Right.
So metabolic cause and other differential diagnosis will be in such case, in absence of the family history, will be a cyclical vomiting syndrome.
Yes, right, absolutely. The only why this would not fit with the cyclic vomiting is this is not how a typical cyclic vomiting would present, though there are variations possible. But in a classic cyclic vomiting, what would happen is a child would have multiple episodes within the first 24 hours, almost 15 to 20 episodes, and would have almost 8 to 10 episodes in the first 4 hours. And after that, the last vomiting, maybe even bilious, and after that, the child would prefer to sleep and would be okay. This child had far more neurological symptoms, just 1 to 2 bouts of vomiting, and the child had slurring of speech. So indicating that there is something more with the brain. So where we would like the first test. So any child who presents like this with altered sensorium and vomiting followed by altered sensorium or just altered sensorium, the basic investigation, when we are thinking of a metabolic cause, as someone rightly mentioned, the basic investigations are GLAC that we do, that is glucose, electrolytes, lactates, ABG, arterial ammonia, and ketones. So that is what we did for this child on the first base. And the ammonia came as 222. So which is very high for this child. We would consider for a 6-year-old up to 80, 40, 50 to 60 would be considered as normal. So it was very high, 222. So we knew we are dealing with an hyperammonemic child who's presented with vomiting with an X-linked disorder. The other investigations, the glucose was normal, the electrolytes were normal, the venous blood gas did not show any acidosis.
Hi, Reverend. Phone केला.
So these are the investigations that we discussed. Sorry, sir. And even the lactates was normal. So this covers the entire GLAC investigations: the glucose, electrolytes, lactates, arterial ammonia, ABG, and ketones. Ketones were negative.
Yes.
So how would we like to further investigate this child? We are coming to the investigation very soon because we have three different cases of vomiting. We took 3 short cases instead of 1 long case of recurrent vomiting. So further, we did a blood TMS and a GCMS for a metabolic screen. And the blood TMS showed, Jatin?
Yes, ma'am. Blood TMS showed low levels of citrulline and arginine. And this was the urine GCMS reports.
Go ahead. Next slide.
Which showed presence of uracil and orotic acid in the urine.
Which is suggestive of a urea cycle defect. So next slide.
Urinary orotic acid also showed elevated levels of urinary orotic acid.
And next. So yeah, very interesting child. And I think the moderators have come to at least that is what we need. A metabolic disease is what we are looking at. And that is what we want to investigate further. So the blood TMS and GCMS generally can help us very well. I don't know if my marker will not be seen, right? So how this TMS and GCMS can help us, and especially when we are looking, so OTC deficiency among the urea cycle defect, that is the ornithine transcarbamylase deficiency, that is between ornithine and citrulline. That is an X-linked disorder among the urea cycle defects, because here with the family history, we are looking at an X-linked disorder. Also, that is one of the commonest disorders among the urea cycle defect. Other is what we are looking at is, this is the girl child, and that is why she presented with milder symptoms as compared to all her male siblings. And in OTC deficiency, typically because the ornithine to citrulline conversion is not there, so citrulline will be low and the arginine will be low. And because the ornithine is then diverted to formation of uracil and orotic acid. So this was a classical case of a ornithine transcarbamylase deficiency. Next slide. So this is just a slide on approach to hyperammonemia. So this is a child who presented with vomiting, altered sensorium. We did our GLACs. GLACs, everything else was normal, only the ammonia was high. If there was acidosis, we would have thought of organic acidemia or fatty acid oxidation defect. When there is no acidosis, we would look at specific amino acid elevations and accordingly reach the diagnosis, whether we are dealing with an OTC deficiency or a carbamoyl phosphate synthetase deficiency and so on. Next slide. So we sent finally, just for confirmation, we sent a whole exome sequencing. The child, so any metabolic disorder, the most of the metabolic, so here now on retrospect, of course, initially even we thought of milk allergy. What this child was for many years, this child belongs to a doctor family, and for many years the child was treated as milk allergy. So what actually was there is this child had a protein aversion. So she was a vegetarian, and the only main source of protein in her diet was milk, paneer, curd. And whenever the child used to eat too much of that, she used to have vomiting. So the child had aversion to protein. So that is again one more important feature of a urea cycle defect. Any metabolic disorder, as we say, we always start on 10% dextrose because we want to stop the catabolism at that time. And the child was then started on sodium benzoate along with the supplements. Next slide. I can go ahead. Next. And this way the ammonia settled. And then the child was discharged on sodium benzoate along with critical. Next. And this was the 4th generation. Of course, we did not take this 4th generation family history in the beginning, but this was the 4th generation. So if we see the great grandparents, 3 male children were lost. And even in the grandparents, one maternal uncle also was lost. And even in her sister, 2 male children were lost. So there were a lot of male deaths in the family. Next.
So child was continued and discharged on sodium benzoate, carnitine, thiamine, biotin, and citrulline. Gradually, the sensorium improved, vomiting reduced and stopped, and child was discharged.
Next. Yeah. So we can go on to the next case. Any comments from the experts? Sir?
Even if there is a metabolic cause, child may present as a variable depending upon the basic etiology.
Yes.
So this child presented quite late because of the X-linked recessive type of inheritance.
Yes. And also one more important feature is this child did have an MRI finding of cisterna magna, giant cisterna magna. So that could have been, I would say, taking us away from the root cause. So it was important to investigate. So we got a neurologist opinion who said nothing to do and just observe, and that is not the cause of vomiting in this child. We just bought this because it's an interesting case. We did not want to, obviously nobody can make this diagnosis on the basis of the history. That is definitely there. It was just because it's an interesting case of recurrent vomiting. That's why we got this. Yeah.
And again, this case stresses the importance of dietary history during
Yes.
our case also, because dietary history in detail would have led to few clues.
Yeah. So I think we got good points from the experts. One is the diet that sir asked, any specific food aversion that the child had. Second is about the family history. I think both these histories were very, very important. That's the next case.
Yes. So now we proceed to case number 2 about recurrent vomiting. So we have a 3-year-old female child who is vomiting on and off since the last 18 months. Initially, vomiting used to happen once a week, but now it has increased in frequency and there are multiple episodes. Each episode lasted for 1 to 2 days with 4 to 5 bouts of vomiting. The vomiting was non-villous and non-projectile, and vomitus contained previously ingested food particles, sometimes stale food, but there was no blood in the vomits. Yes, ma'am.
Any other associated symptoms? Pain in abdomen, constipation?
No significant constipation and no pain in abdomen as such. Not much because she's a 3-year-old child. She used to just on and off vomit. And after the vomiting, the child used to be completely normal. And it was always non-bilious. But one history that is classically there. So this vomiting was not there till 18 months. And after that, the vomiting started. And whenever the child used to intermittently vomit, but whenever she used to vomit, she used to bring out a lot of vomit, 4 to 5 times she used to vomit. One important point that the parents themselves said is what she has eaten today morning may come out even the next day evening. So the green khichdi that she used to give, even that has come out on occasions in the vomitus. So stale food was there. So what would that tell us? So are we looking at anything which is obstructing? So is there any obstruction which is causing the food to accumulate and then the child is?
That's what there seems to be some anatomical problem,
right.
Some obstruction, some level, and that is causing. It's non-bilious means the level we know,
yes.
And so that's why I asked this upper distension over upper part of the abdomen and pain. The symptoms are not there.
Yes, sir. So distension as such they didn't describe, but then when we repeatedly asked them, they said just normally she's okay, but just before the vomitus, the child has slight fullness. She vomits and then it becomes normal. So what would be the differentials in this child? So anatomical obstructions.
Anatomical obstruction, malrotation.
And in anatomical obstruction, either an esophageal obstruction like in achalasia, or a gastric outlet obstruction, or are we looking at something beyond that like a duodenum, but restricted above the second part of the duodenum, as you rightly said. So how would you like to investigate? So what would you like further, sir, in this case?
How this child is growing anyway? Growth of the child is normal?
This child's growth was not normal. the child did have poor growth. The child was growing below her centiles. And she always preferred a liquid diet. So while the child was on liquids initially, the child did not have vomiting till the age of, like we see, till the age of 18 months, the child was okay.
Okay.
We want to ask for any history of
And
cirrhosis, like any event which suddenly caused this.
Vomiting is related to particular food, or it's with all type of foods and all?
So all types of food, solid. So when she eats, if she's on a liquid based diet, she's okay. But if she's on solids, she's not okay.
how is the child developmentally, madam?
Normal child, absolutely normal.
So along with reflux, GERD is also one possibility in this case.
So here, in fact, we would say, so there are points. Okay. So in fact, this child was referred as a case of GERD and they referred for milk scan and a gastroscopy to look. But there are many points which were totally against a GERD in this child.
Manifested late.
Yeah,
started at around 1.5 years.
It did not start at birth, it started at 18 months.
Yeah.
And GERD would be worse on liquids. This child was better on liquids.
Yeah.
So our other thought was achalasia. So even in an achalasia cardia, it would be worse on liquids. So solids will still go. Liquids will be, dysphagia to liquids is far more common in achalasia. So even achalasia cardia was not there. So this is only on solids that the child is having problem. And there was no chewing difficulty. Child was developmentally normal. One important point that you asked is, was there any abdominal fullness? So there was. So as a parent said, slight abdominal fullness they could feel just before the vomiting. And sometimes they could hear borborygmi-like sound from the abdomen before the child used to vomit.
So after basic profile of this child, would like to go for upper GI and endoscopy in this child.
Yes. So X-ray abdomen is the first thing, radiography. So we'll do an X-ray abdomen to look for any. So she was initially, in fact, referred as GERD, but as we said, discuss the points of why this is not GERD. We'll get an X-ray abdomen. Latin?
Yes, ma'am.
And on examination, the child was otherwise completely normal. All the systems were normal. But only on the abdominal examination, there was a mild fullness in the upper abdomen with a gurgling which was felt in the left hypochondriac region. So this gurgling, the borborygmi, that typically tells us probability of an intestinal obstruction. So the next investigation, as we said, would be an X-ray abdomen. So this was the X-ray abdomen of the child, which did not show any air fluid levels as such. And there was air which was seen even in the lower intestine and in the large intestine. So suggesting that it's not a complete obstruction that we are dealing with. Next investigation, what would we do in a child who is having vomiting, recurrent vomiting, where we are thinking of an intestinal or upper GI obstruction?
Scopy, upper gastroscopy.
Yeah. And before that, just to get the anatomy, this thing, we can do the gastrographin study study to find out the level of obstruction.
Yeah.
Yes. And her multiple USGs showed gaseous distension of abdomen, because of which they could not comment. So the next, the child underwent barium swallow and barium meal. This was the barium study in this child. So would you like to read this barium, sir?
Stomach is it's dilated.
Yes.
And
even the duodenum. Yes.
Yes, the duodenum was dilated.
Yes. Yeah. So as sir rightly said, and the esophagus is fairly normal. Though the lower part is not seen in this, but the radiologist mentioned there's no bird beak appearance like in achalasia. So as sir rightly said, the stomach is distended and there's a significant distension of the duodenum. And after that, we see the normal intestines. Yeah, so it's though not classical, but the radiologist did suspect that there is a probable windsock deformity suggestive of a windsock appearance, which could be of a duodenal web. So as rightly said, then we went ahead with an endoscopy for this child. The basic investigations were all normal. So in this, the first picture, so we've directly taken from the, started from this. So first picture is of the first part of duodenum. Normally the first part of duodenum is very narrow. We don't have so much space. Here, the first part of duodenum was significantly dilated and there was stale food which was accumulated in the duodenum in spite of the child being fasting for almost 12 to 16 hours. So this all was the previous food which was there. And just beyond that, in the second picture, if you can see, that's the duodenal web. It's a flappy duodenal web that was seen. So previously for duodenal webs, they used to do a surgery where they used to do a duodenotomy, cut incise it longitudinally, then stitch it transversely. But now we have started doing less invasive procedures, that is endoscopic dilatation. Of course, after ruling out other anatomical anomalies like annular pancreas or pre-duodenal portal vein, if they are not there, we can go ahead. And this is a balloon, this is a CRE balloon with which it was dilated. And after that dilation, the scope could easily be negotiated through it. Jatin, go ahead.
Yes.
Go ahead, Jatin. You can.
So post-procedure uneventful, there were no further vomiting episodes. Child was discharged, and since the last 4 years, there is no further vomiting episodes. Child is well, growing, and not required any further endoscopic evaluation.
So any comments? So we had two different cases of vomiting, both presented similarly, recurrent. But first was a totally different, and this was anatomical. So I think, so your comments.
Onset of symptoms, symptom pattern, associated symptoms, family history, and all these are the clue to suspect a diagnosis and investigation also.
Yeah. So I think what was the first case with a significant family history, having neurological symptoms after the vomiting points us towards metabolic cause. Here, a child who is not growing well, multiple bouts of vomiting, and most the points which clinch history in this child, clinch the diagnosis in this child were one, stale food vomiting. So very unusual that the child is eating green khichdi today morning and vomiting out the next day. We would think of achalasia as the first diagnosis whenever such a child comes, stale food vomiting. But in this child, it was not achalasia because the child was tolerating liquids but not tolerating solids. So that was a picture. So typically, and why this child was well till 18 months was probably because the child was on a liquid diet and the web was allowing the liquids to pass. So somebody in the chat also mentioned like a partial duodenal obstruction. So that was it. So that is what a duodenal web is. It's a partial duodenal obstruction. And the bilious and non-bilious vomiting tells us the site of the obstruction. That is, it's beyond the beyond the papilla or above the ampulla of Vater. And somebody's asked why the X-ray did not show air fluid levels. So typically, I think what was happening is this child has partial obstruction, and this child, when they presented, the child presented post multiple bouts of vomiting. So that's why we did not get any air fluid levels. So this not show any, but the barium did show a massively dilated stomach and a massively dilated first and half of second part of duodenum. And the investigation, whenever we are suspecting an anatomical cause, would be to start with a plain X-ray abdomen erect, followed by upper GI contrast studies. So if we are suspecting a perforation where we are worried about risk of mediastinitis, then we would go with a water-soluble contrast like a gastrographin contrast. Otherwise, when we are looking at obstruction, we can give barium. So we can give barium. So we can do a barium swallow, a barium meal, and follow through. We'll go to the last case. Any comments, sir? Or should we go ahead?
We will go ahead with third case.
Go ahead.
So third case, case number 3. So we have a 8.5-year-old female child. She complains of abdominal pain and vomiting since 3 years of age. The vomiting is recurrent in nature, non-bilious. Initially, it used to happen once in 3 months, but since the last 6 months, episodes happen every month. So it starts with vomiting, usually one bout, followed by abdominal pain, which is colicky, severe in intensity, diffuse in nature, no diurnal or postural variation. But the child is absolutely normal in between the episodes.
So here we have a child who has stereotypic, exactly similar episodes of vomiting, and they occur exactly in the same pattern. So when we ask his mother, can you, so she says, I know exactly what is going to happen. Of course, the interval changed, but the child typically used to have exactly same episodes. The child used to complain of some slight uneasiness, and the child used to vomit. And then vomiting was not that severe, and abdominal pain was far more severe. The child has to have severe abdominal pain. And in between episodes, the child used to be absolutely normal. And this is a well-grown child.
Any other associated symptoms? Constipation, distension of abdomen?
No, no history of any constipation, no abdominal distension, no history of any headache.
Next up, headache.
पाच मिनिटं. हा बोल ना.
Any marker on general examination and systemic examination?
Examination was completely normal in this child.
10 मिनिटं 10.
Like developmentally normal, and how is the school performance, madam?
So good. School performance is also good. The child likes going to school. Though a few of these episodes were during exams, the vomiting and the abdominal pain were during exams, but not all of them. There were episodes even while the child was on holidays.
Okay, on holidays also had
Even
problem.
in vacations, the child has had pain and vomiting. So there is one thing that we never want to miss in a child who has severe abdominal pain and vomiting is malrotation. Though this is not the classical way that a malrotation presents, but that's a dictum for us that if a child has abdominal pain which is very, very severe and there is vomiting, we rule out malrotation. Of course, we don't go very invasive when our doubt is less. So we just we have a good sonologist. So we ask him just to look at the USG Doppler and tell us the SMA-SMV relationship.
Pattern will be a little bit different when malnutrition
they
is
will
there.
have bilious vomiting. Everything will be totally different.
And the pain will not be of a fixed type similar to what is in this case.
Yeah. These were the investigation that the child had already come to us with. So they had already had a barium meal, they had a barium meal follow through, X-ray abdomen, everything was normal. So Doppler, SMA-SMV relationship was also normal.
Cyclical vomiting and functional abdominal pain, these are the first two possibilities now.
Yes. So very rare, sir rightly said, cyclic vomiting is a strong possibility. But what goes against, so we are looking at something very similar to, so what you said is right, you're very close to the diagnosis, sir. Cyclic vomiting, typically the vomiting is a lot. They, as I said, they will vomit almost 10 to 15 times in a day in the first 24 hours. This child, and they will also have abdominal pain. In this child, just 1 to 2 bouts of vomiting, but abdominal pain was far severe.
Severe.
Very severe abdominal pain. So another, which is a close relative of cyclic vomiting, is the next, Jatin, just go. So we suspected abdominal migraine.
Yeah.
So abdominal migraine is similar pathophysiology. Again, we will get a history of migraine in the mother. The child will have what classically clinches an abdominal migraine or cyclic vomiting is stereotypy of the symptoms. So when the mother says that she can predict that now the child will have abdominal pain, It will last for around so many hours. And after 2 days, she is 100% sure that the child is going to be normal. So that tells us we are probably dealing with that. In no other condition, whether it's gastroenteritis or any infections, they will all behave differently. But these functional pains typically have a classical stereotypy. So, and there we had the diagnosis because the mother had history of severe migraine. So because this child had a lot of very severe, so generally for abdominal migraine, we don't start with medication straight away. We first start them with, avoidance of fasting. We will we'll identify we'll try to identify if there are any food triggers or any stressors which are causing this. And we'll try to avoid all that. But this child was very, very severely affected, was having very frequent episodes. That's why we started with a medicine for her. So we started with flunarizine for her and she saw marked response to it. The next 3 to 6 months, she did not have a single episode. And then we gradually tapered and stopped flunarizine along with the lifestyle measures for her. So we've had 3 different cases of vomiting that we had. Recurrent vomiting. So metabolic, anatomical and functional. So everything, the child will be normal. And almost all of them, the child did not have very severe failure to thrive. They were all pretty okay. They were all in the same age groups, around 7 to 8-year-old girls. 3 different girls who all had recurrent vomiting in between episodes normal, but 3 totally different diagnoses. That was what our point was. I understand these were little different cases, but we just wanted to highlight these cases because these are common cases. We are going to see them in our practice.
Jatin, very nicely presented all 3 cases.
Thank you, sir.
And excellent collection, Dr. Dimple.
Yes, sir. Sir, we can't hear you.
Hello.
Hello.
Yeah, now we can hear you.
Yeah. Thank you, Une sir, our expert, Dr. Une sir, Dr. Rathod sir, our moderator, Dr. Dimple Jain madam, and presenter, Dr. Jatin. All the 3 cases were very interesting. The first was metabolic. Then the second was an anatomical obstruction. And the third one was abdominal migraine. And all of them, most of our experts reached to the nearby the diagnosis. So I really congratulate both of them. Thank you, everybody. I now request Minas sir to give a vote of thanks.
Thank you, Joshi sir. I would not take much of time, but one must say that the cases, all the 3 cases were too good. In fact, it has been real learning. I mean, when you go more into deep, you know how much less you know. I mean, all the 3 cases have been phenomenal, well worked up, well presented by Jatin. Congratulations, Jatin. Well done. So also Madam Dimple Jain, who has mentored Jatin very well, and she was very it was very impressive to listen to her, because one thing I noted that she has not repeated any word. Every single word was different. So congratulations, Dr. Dimple. It was pleasure having you on board. So also our expert Une sir and Rathod sir. One must say that our expert does not know the cases.
Absolutely.
So without knowing the cases, coming on a platform itself is a challenge, which has been accepted by Une sir and Rathod sir, and they have converted this challenge to opportunity. So thank you, sir. And thank you, MahaIP team, led by our President, Dr. Pakmode sir, our Secretary, Dr. Amul, Treasurer, Dr. Sagar Sonone sir, my colleague, Sanjay Joshi sir. And I am looking at a couple of senior with me. If we can have a small word from them. One is our own immediate past President, Dr. Ramakant Patil, who has been an excellent academician. So 2 words from your side, sir. Ramakant sir.
Yeah, good evening, Joshi sir, Une sir, and thank you, Minas sir, for giving me an opportunity to talk. I was trying to chipping in with chat.
Sir made all the diagnosis straight.
What an excellent collection of non-bilious vomiting on girls and different age groups. Wonderful. And we day in and day out see, and that the duodenal wave diaphragm with central
Yeah, very good.
that is whether there was this thing any associated genetic
No
abnormalities.
trisomy, nothing. So they are more associated with trisomies or with annular pancreas, preduodenal potential. Nothing was there in this child, luckily.
Any malrotation in that particular case, madam?
No, sir. We did see for malrotation. In fact, they
Ah.
are associated with malrotation. So before going for an endoscopic procedure, we checked all that, sir.
Yeah. Okay. Now how you did it check? You did CT or you did sonography?
Sir, SMA SMB relationship.
SM relationship you have seen.
Yeah,
Understood.
and the barium study that we had done, when that barium
Yeah.
passed, we could see the position of the cecum, so we ruled it out.
Yeah. And SMA interesting for that particular thing. Yeah.
So all
Ravindra Joshi sir, please off your video, please. Ravindra Joshi sir. Ravindra Joshi sir, your video off. Please make your video off.
Minas sir, all
Yeah.
this
Thank you. Yeah.
and malrotation will have bilious vomiting. That
bilious vomiting. Agree.
that becomes a very important difference.
Important part. Yeah. Yeah.
So these three cases were absolutely non-bilious vomitings and wonderful collection and very excellent lead, as Dr. Minas sir has said, that Dimple Jain madam giving opportunity to the presenter at the same time giving excellent synopsis. Thank you.
So
Dimple
I
Jain
wish I invite Dr. Jayashree madam. Jayashree
Dimple
madam,
Jain
your
madam.
comments.
Yes, sir.
Was the EEG abnormal in abdominal migraine?
We didn't do an EEG, sir. So EEG is not recommended for abdominal migraine. There is some role in abdominal epilepsy, which we can see. So if there is an abdominal epilepsy, we will do an EEG where we will get typically those spikes in the occipital lobe on the EEG.
And anyway, the abdominal epilepsy term has been now abolished.
Now it's like, yeah, there's a wastebasket term.
So we don't call it as abdominal
epilepsy.
Yeah.
Jayashree madam, your comments, 2 words from your end. Our senior pediatrician from Palghar. Jayashree madam, are you there? I think she's not around. Then I can see Rajesh Kulkarni from Pune, our EB member, an good academician. Rajesh?
Yes, sir. So very interesting cases and unusual presentation in 3 cases.
Yeah, a lot to learn.
Really, I must say, wonderful. And out of the, these are unusual cases, and generally abdominal migraine is kept as a dumb diagnosis when you don't know what to do. So
But
really
we are
excellent
seeing
cases.
them. I would not deny that abdominal migraine is non-existent. It is very much existent.
Yeah, we consider it very rare.
Yes.
I think what the mind knows, you see, isn't it? So that is what
We
is
have a
happening with
referral bias.
abdominal
I think
migraine.
we see only abdomen, so that is why
Yeah.
probably, yeah.
Yeah, but there are cases. I think we are not diagnosing them, so we must make efforts to really pick these up.
Yeah. Anyone would like to add on? You can have 2 words and then we'll wind up.
So the presentation was very concise, clear, and very short. There was not a single unnecessary word, but still it was the presentation maintained the suspense till the final diagnosis. So it was very nice experience in that sense.
Yeah, it's a good experience. Yeah, Sagar, you want to add something? Sagar is there or gone? Okay. So if
I'd like to thank Maha-AP for this opportunity. It was really a very interesting case, cracking the case. Frankly speaking, I'll just say, Jatin, thanks, very well presented. And I must say, Minat sir, thank you very much and everyone for giving this opportunity. And while preparing the slides also, I was worried that how am I expecting the experts to decode this? It is difficult, but our experts did a very good job. They did come in the first case, they did come to a diet, the whole metabolic history. In the second, they did come to an anatomic cause. And in the third also, they did reach a functional diagnosis. So thank you, experts. It is definitely a very difficult job to do when you all did not know the case at all. Yeah. So very nice. Thank you.
Yeah, thank you. Thank you all.
Dimple.
So
Thank
with
you,
this, we
everyone.
conclude. Yeah. Jatin, you want to add something?
Yes, I would like to thank Maha-AP for this opportunity and especially Dr. Dimple ma'am to share such good cases with me, because when we were making this presentation and going through the files and everything, we got to know, I as a DNB resident got to know what to see more when we get such cases of vomiting. So I thank Dimple ma'am especially for this.
Yeah, and the entire objective of these kind of presentations and webinar at MahaIP is to, get the best out of and reach to someone we have not reached. So that we are getting a lot of gems from Maharashtra. We get a lot of people like Une sir, Dimple madam, Rathod, Jatin. So we come to know a lot of new people with us, and that is what exactly we want in our journey towards science in the MahaIP. So thank you all.
Thank you.
We conclude over here. Thanks to entire MahaIP team, including our technical support from Nasik, Madam Pallavi Dharmadikari, Secretary, President, Secretary MahaIP, OB, EB MahaIP, Central EB, all. And we meet again the fifth Friday, because next month we have Pedicon. So second Friday will not be doing, but will be doing on third, fourth, and fifth Friday, and the first Friday. So thank you, Sanjay Pakmode sir, and the entire MahaIP team. We conclude over here. Thank you.
Thank you so
Thank
much.
you.
Good night.
Thank you. Thank you.
Thank you. Good night. Bye.
Thank you. Good night.
Good night.